Non-medical prescribing assessment by Joanne Rymell. So this video aims to meet certain objectives. They are to introduce the patient for the purpose of this video, go through their medical history and the clinical presentation, discuss pharmacokinetics and pharmacodynamics of the medication I chose to prescribe, look at the ethics of prescribing practice and implementation, review professional responsibility during consultation, review key issues of non-medical prescribing and continue professional development, and the last slide is a reference slide. So the lady that is in question for this presentation is a 30-year-old female who presented for consultation in February 2020 with a view to obtaining wrinkle relaxation treatment. She believed she was beginning to see the emergence of crow's feet and frown lines. The lady had done her research and she articulated to me that her reading had enforced the belief that prevention is better than cure, where the ageing process is to be considered, and was subsequently presenting for treatment at this time. On taking a medical history, it was established the lady suffered with gestational diabetes during her only pregnancy to date. She was now 18 months postpartum. She was not breastfeeding. She had never received wrinkle relaxation treatment before, had no known allergies and takes no other medication, and had no other remarkable medical history of note that was generally fit and well. On clinical examination, age-related lines were evident bilaterally on the forehead as well as the crow's feet around the eyes, slightly more predominant to the right side. Also of clinical note was a very dry erythematous area on the left side of her medial cheek extending up to the temporal area. The skin had been broken in one place and was typically characteristic of atopical eczema. On further discussion with the client about this dry patch, she acknowledged she had suffered with eczema extensively as a child that had largely subsided with the exception of the occasional flare-up to her hands and face, which always coincided with the winter months and cold weather. I was very confident at this point to make the diagnosis of eczema. I discussed my findings and diagnosis at this point with the client. She was already aware of the visible patch of eczema and was happy with the diagnosis. I informed her that my first responsibility is to treat the eczema before we can address the issue of wrinkle relaxation, which was the reason for her appointment. I advised her that Nemolic would be required to treat the eczema and that I will get her back in for review in 3 weeks. At this point, if the problem had resolved, I would be happy to treat her for wrinkle relaxation with 125 units of Azolo. The client fully understood and concurred with this treatment plan. Azolo is a botulinum toxin type A. Consultation has a vital role in any client or patient journey. The idea of consultation models have evolved as the role of the nurse prescriber. Consultation models are used in healthcare as a framework and a guide for the practitioner when in contact with a patient to promote a holistic, systematic and patient-centric approach to consultations in order to create well-being and therefore promote a safe and evidence-based management plan tailored to each patient. Nuttall and Howard 2015. Most consultation models are split into two types, either normative or descriptive, i.e. what does happen and what should happen during a consultation. In this specific consultation, I favour the Pendleton et al. 1984 model as it is patient-centric, which allows for the client or patient's concerns and ideas and expectations to be addressed, which is extremely important in the light of an elective nature of treatment that the client is presented for. The BACN, which is the British Association of Cosmetic Nurses, offers guidelines for prescribing in medical aesthetics. This is 2012, which clearly outlines that in order to assess a patient or client's conditional condition, certain parameters must be adhered to, and these are to undertake a thorough history, including a medical history, a medication history, and diagnose where necessary, including over-the-counter medicines and complementary therapies, decide on management of presenting conditions and whether to prescribe or not, identify appropriate products if medication is required, advise the patient/client of any side effects and risks, prescribe if the patient/client agrees, monitor response to medication and lifestyle advice. It also states that the patient is at the core of any decisions to prescribe and the patient's needs are considered without reference to financial gain. My methods, observations, discussions and subsequent treatment plan, which was agreed with the client, were perfectly aligned with both patient-centric consultation model and the British Association of Cosmetic Nurses guidelines on consultations. This gives me two clear parameters by which I was able to plan, execute and evaluate the consultation process. With the pharmacokinetics and pharmacodynamics, botulinum toxin type A is a neurotoxin protein produced by the bacterium Clostridium botulinum and other related species. It essentially prevents the release of acetylcholine and subsequently affects muscle relaxation. It's mixed with bacteriostatic saline in order to create a neutral pH at the site of injection, therefore allowing non-toxic components to rapidly separate from the neurotoxin part of the molecule. The neurotoxin molecule then spreads away from the injection site, which can obviously cause side effects if any non-targeted structures are reached, for example in the case of a botulinum toxin-induced ptosis. Although intradermal injection carries more minimal risk of this type of occurrence compared to subcutaneous or intramuscular injection. The primary mechanism for absorption is binding and transport across the epithelial cells. Toxin that enters the body undergoes a distribution phase, which is quite short, and an elimination phase, which is comparatively long. During the distribution phase, botulinum toxin migrates to the perineural microcompartment in the vicinity of the vulnerable cells, such as the collagenic nerve endings. When the toxin moves from the cell membrane to the cell interior, it undergoes programmed death. Botulinum toxin type A exerts high tropism for neurons based on its specific binding site on neuronal terminals within the affected area. The high specificity binding is due to the high affinity interaction of heavy chain and its neuronal binding state. Botulinum toxin type A has outstanding potency following only one treatment due to the different toxin protein subunits which mediate its high affinity recognition of neuronal targets and its intracellular enzymatic activity targeting the synaptomosal associated protein 25. This is also known as a SNAP25. The most important factor affecting longevity of a toxin is the ability of the botulinum toxin type A proteins to avoid cellular degradation mechanisms and survive in cell plasma for long periods of time. Relatively little is known about the life cycle of botulinum toxin type A. Systemic metabolism and elimination is thought to be via the liver. Ethics of prescribing and practice inform consent. As a nurse prescriber, I must act in accordance with the code, professional standards of practice and behaviour for nurses and midwives. I therefore made it clear to the client that prescribing activity cannot be undertaken in isolation. I am obligated to inform, where relevant, anyone else who may be able to prescribe to the client of my actions in order to avoid prescribing errors, although it is not particularly relevant in this specific instance. I also inform the client of why the proposed treatment is being recommended, the expectation of the treatment and any potential side effects of using both emollients and botulinum toxin type A. A follow-up was agreed with the client and clear notes made of client information, medical history, allergies and treatment plan. Relationship to client. I have never met the client previously and she was no relation to me and was not known by myself or any of my close friends and family, so was completely within the scope of ethical prescribing practice. Acting in the client's best interest. My actions in respect to the client's treatment plan were completely aligned with this principle. By addressing the eczema ahead of any other treatment, I was serving the client's best interest to promote their health and well-being. While certain aspects of ethics of prescribing are very clear and concise, such as privacy and confidentiality, due to the very nature of prescribing, it is also a critical skill which requires continual practice, knowledge, experience, analysis, examination and evaluation. Ethics can help to make the final prescribing decision as well as play a role throughout the whole consultation and prescribing process. Informed consent is only implied on a client entering a medical or cosmetic treatment room. So at the point of treatment, consent was taken from the client in written form and their written permission also to take photographic evidence to add to their notes. Consent is an important ethical concern based on the principle of autonomy, so a medical practitioner can act as a facilitator in the patient's decision making. J. Catan, 2008. The client was consulted on her opinions and we reached a mutual decision to prescribe 125 units of Azolo botulinum toxin type A, as opposed to other brands such as Botox on this occasion. Many clinical studies have taken place over an extended period of time, and many clinical papers have been written on the different brands of botulinum toxin type A, and almost all concur there has been no clinically significant difference for patients found to date between the brands. See Jürgen 2010 and Dover et al. 2018. Professional accountability and responsibility. Records of prescribing. I made concise and coherent written notes of the consultation and my prescribing practice that can easily be reviewed and understood if necessary at a later date by myself or another medical professional. Leadership skills and relationship of public health requirements in prescribing practice. I had an in-depth conversation with my client about my responsibility to promote health and well-being ahead of a secondary elective treatment. In this case, that meant needing to treat the eczema first and foremost ahead of providing an elective procedure. The client was able to fully comprehend the reasoning behind this decision, and she was perfectly happy with my proposed treatment plan in this specific case. Relationship of the prescriber to pharmacist and potential for drug misuse. After informing the client of the diagnosis, I was able to advise her Nimodin would be required to treat the eczema. I suggested the use of Diprobase after checking the Sheffield CCG formulary, which listed Diprobase first line, but suggested this could further be discussed with the pharmacist, as these are available over the counter and the pharmacist can show the client all of the appropriate options which are available and currently in stock. In relation to the wrinkle relaxation treatment, I advised the client that once the time was right, following the successful treatment of eczema, I will be happy to prescribe 125 units of Azolo botulinum toxin type A, which I will source from an aesthetic pharmacist with whom I maintain a close professional relationship, therefore negating any potential for drug misuse of a controlled substance. Key issues for non-medical prescribing and continued professional development. Continuing professional development for non-medical prescribers is recognised as being pivotal in maintaining up-to-date knowledge and skills influencing a prescribing competence. Clinical supervision is also an essential element of the clinical governance framework for non-medical prescribing. Responsibility for continued professional development. As an NMP, I am responsible for my own ongoing CPD portfolio and professional portfolio, keeping up to date with clinical evidence and best practice within the field of prescribing. Non-compliance with this can result in the prescriber being removed from the clinical commissioning group non-medical prescribing register and subsequently being unable to prescribe. CPD requirements should be identified at least annually during the non-medical prescriber's appraisal. As my mentor has agreed to be responsible for reviewing me as a non-medical prescriber, I have agreed a timetable with her to meet and discuss competencies, prescribing and continuing professional development. This will be more frequently initially due to me being a newly qualified non-medical prescriber. And key issues: continual adhering to the guidance and framework such as the Royal Pharmaceutical Society, the National Institute for Health and Care Excellence Medicines Prescribing Centre Framework, the BNF and NICE guidelines, and peer group review networks locally with other prescribers to ensure and promote safe and effective prescribing. I will also be conducting regular audits, formula reviews at local and national levels to remain current in my prescribing practice. Participation in industry-related education events, speaker meetings, and further courses to upskill and continue learning in order to improve patient/client care without compromising safety, to facilitate easier access and to increase patient and client choice, and to source the care, medicines and treatments they are looking for. And lastly, here is the list of references that helped me make this presentation. Thank you.